Tell me when. Good afternoon. I think it's, oh, sorry, it's morning. I'm used to doing this in the afternoon, and this week it ended up being on Friday and in the morning, so I apologize. Good morning. Quick reminder that we do have a chat feature through YouTube if you're watching this live. We've gotten some feedback that people sometimes have a hard time, particularly if they're watching on their phone, accessing the chat feature. It is available, it's just in a slightly different place, a little harder to find. If you're not able to find it and you have a question you want to ask, you can email Tina Young, my assistant, during the presentation. If it comes in during the presentation timely, then she'll get it to me and I'll answer the question during the presentation. Otherwise, we will get back to you afterwards. And through this process, we have gotten pretty consistently the occasional question will come afterwards, and we do our very best to answer that. So here we go. All right, so we now have almost 23 million COVID cases across the United States, with now approaching 800,000 deaths. Or I'm sorry, this is in the world. Almost 23 million cases in the world and approaching 800,000 deaths. In the United States, we're over 5.5 million. And so we are about a quarter of the world's cases and 174,000 deaths in the United States, which is also about a quarter of the world's deaths. In California, we're up to 638,831 cases with 11,523 fatalities. That's increased by about 65,000 since last week and over 1,000 deaths. Across California, our overall positive rate is 6.6, which has went down a little bit. But in Fresno, we'll talk about that's not quite where we need it to be. In Fresno, we have 22,167 cases now and 205 deaths. So we've increased by a little over 3,800 cases since our last update and 14 deaths. I did want to show you this slide. This is a newer slide on the public health website. And public health this is called an epidemiological curve, and it's different than the case curve that you saw on the previous slide in that epidemiology in the public health department is, as they do their case investigations, they're looking at the actual date that someone became sick or took the test or the first date we could possibly know that they had COVID. And the reason we're doing this is to have a more accurate reflection of the prevalence of COVID in our community at any time and over time. So the episode date in this curve is identified as the earliest of the following: the date the positive test was received, the date a diagnosis was given, the date that symptoms were onset, the date that someone died, if that was the earliest date known, or the date of the specimen collection date. So as they do the investigation, they collect all of those dates and information. And previously, or on the prior slide, the date that the positive test result is recorded by the lab is where the case resides. On this slide, it's that episode date. And so the episode date is a more accurate reflection. And so I thought this was an interesting slide. Of note, to the right on the graph, you kind of see a shaded area, and that's really, that's where the least reliable information is, because for cases that are recorded during that time frame, or for symptoms that develop during that time frame, those people may not have gotten a test result yet, they may not have taken a test, their symptoms may not have developed it. So if you acquire COVID over that 2-week period, we may not know it yet. We may not have that recorded. So there'll always be that period of time on this graph that is a little less reliable. But what you can see generally on this graph, consistent with the other graph, is that we had a real peak towards the end of June. And remember, we opened up in late May, I believe, and so people went back to normal too much, and we got a lot of cases. And then as we shut things down, the number of cases has steadily declined. But what we're not sure of is really exactly where we're at now. All right, in terms of hospitalization, I have some good news and some bad news. So our hospitalization has definitely continued to decline. We had a couple of weeks ago 295 hospitalized. Just prior to that was 314, so that went down. Then 273 hospitalized last week. Now it's 245. That's less. Well, a few days ago it was 235. So we're going to watch this closely. A little bit of fluctuation is, statistically insignificant perhaps, but the other number to focus on is the number of people in the ICU, and that's actually went up. So we were at 55, then 56, now we're at 61. And remember, people get exposed, and then you see cases increase, and then trailing that is hospitalization, and then trailing that is deaths. So there's a little bit of a trailing with ICU stays as well. People get sick, and maybe they don't get put in the ICU right away. So just something for us to keep an eye on. This graph is a newer graph from Public Health with similar information from that last graph. So I showed you the Public Health graph for cases. This is the one for hospitalizations. And this really shows you over time, if you look at the darker upper part of the graph, that's the number of hospitalized patients, with the lighter lower part of the graph representing the individuals who are hospitalized in the ICU during that time frame. And so the ICU has went up and stayed, at a fairly up since about the beginning of July, and the cases started rising a little sooner, as did hospitalizations. All right. So our watch list statistics, and remember the watch list is essentially a rolling 14-day retrospective look at certain statistics that the state looks at to determine whether or not a county will be on the watch list. Once a county's been on the watch list for 3 days, that's when the more what people would consider draconian measures occur, where we can't eat indoors, where we can't gather in groups, where schools have to be virtual learning. And so we've went up a little bit in new cases, but remember, we're still kind of sorting through that technological glitch, so it's probably going to be another couple weeks before we can really look at that accurately. The deaths over 14 days has decreased, so we had a spike in deaths that seems to have went down, but deaths get reported a little differently than cases. There's a lot more work that goes into determining that a death was attributed to COVID, and so they don't necessarily track with when a person actually died. And then the number of people tested over 14 days did slightly decrease, but still is well above what the state wants us to be at. And then the test positivity at 13.3 is most definitively much higher than where we need to be, both in terms of getting off the state watch list, but more importantly, getting control of COVID. So I'll remind you again, on the state watch list, you want it to be under 8. But basically, most epidemiologists would tell you that in order to get a pandemic, an epidemic, a virus under control, you need to get it under 5%. So this slide basically is a snapshot of what the state looks at. So they want, in terms of the number of tests per day, they want you to have at least 150 tests per 100,000 population. In Fresno, that's 1,500 tests a day. If you go under 150, that could get you on the watch list. We're at about 220.4, so we're fine there. That we're not on the watch list for that. In terms of either the case rate being greater than 100 per 100,000 individuals, or the positivity being greater than 8%. And so we're not doing well in either of these. Our case rate is 223 per 100,000 people, and our positivity is at least 12.4. Now this slide's a little different than the last graph I showed you because they're different time frames. And then in terms of increasing hospitalization, when we looked at that hospitalization graph, you saw that steep climb on the graph. That's what you have to get out of. If you're having an increase over a 14-day period of 10% in hospitalizations, then that gets you on the watch list. We're doing okay here because we're declining. But just to keep it in perspective, we have 245 people in the hospital essentially today across our county. In mid-June, that was 60. 65. So we have a ways to go before we get down to those lower levels. I've said it before, I'll say it again. In the mode of learning to live with COVID, we should get used to having people in the hospital. What that sweet spot is, what the number of people in the hospital is manageable, is unknown right now, and it really depends on how the hospital is utilized for non-COVID activities as well. And so that's something that it will be a moving target. And then in terms of limited hospital capacity, if there are less than 20% of the ICU beds available or less than 25% of the ventilators are available, that will get you on the watch list. We have plenty of ventilators right now. There's a big push right now not to put people on ventilators. They feel that ventilation can predict a poorer prognosis or outcome, and so there's a lot of other treatments that they're trying before they put someone on a ventilator. So we have enough ventilators, but we do not have the ICU bed capacity that would keep us off the watch list. So these are the things that we'll be looking at as we move along. All right. I wanted to give you a little more information about tests. Sometimes when I talk about tests, I talk about the accuracy, and I was scolded by my husband because accuracy isn't really a term that we use with this type of test, so I'm going to explain to you what terms we use. Laboratory tests are really characterized by their ability to detect a positive case. How successful are they at detecting the presence of a virus? And that's called sensitivity. And then their ability to determine a negative test. How good are they making sure that there's not that virus in there? And that's called specificity. And that can include pieces like not detecting a different type of coronavirus, for instance. So a sensitive test is less likely to produce a false negative. So if a test is really good at detecting positive, then it's less likely that if you get a negative test result that you could actually have the COVID. And then a specific test, a test with good specificity, is less likely to produce a false positive. So when you have that test, if you get a positive result, you can be pretty assured that you have the virus. All right. So manufacturers and laboratories report out on this. They do all the massive amount of research and testing to be able to say for particular types of tests what their sensitivity and specificity are. But keep in mind that analytical results are really under ideal conditions. So they're based on an analysis of a set of known positive and known negative samples. So they're testing known virus and known samples without virus. Real world conditions are much more variable. And that could do with difficulties with the person administering the test and whether or not they're administering the test properly. I don't know how many of you have had the COVID test. I've had it twice now. The first time I had it, it seemed less invasive than the second time. And when my son had it, he took a video, and it was much more invasive than the first time I had it, and the second time I had it, it was more like what my son experienced. So you really have to take that swab and stick it pretty far back into your nasal cavity in order to get, and you twist it around for a period of time. It's a little uncomfortable, and so if you just stick it up and out, you really didn't have a chance to gather all of the potential viral material. And so that reliability with the test administration is one piece of it, and then the difference in viral load of the individuals being tested, including the potential stage of disease they're at. So we know that depending on if you're pre-symptomatic, asymptomatic, or post-symptomatic, you might have a different amount of virus in that nasal cavity where the specimen is being collected. And even more importantly, once the symptoms start, the amount of virus in there changes. And a few weeks ago, I showed you a table or a graph showing that, and I'm going to show that again in just a minute. Oh, there it is. Okay. So this shows you that the virus in your airways, that's the blue line on the left-hand side, changes over time during the course of the disease. And then the antibodies in your blood change over time as well. So depending on the days pre and post onset of symptoms or even asymptomatic, you have a different amount of virus. So depending on when in that process you get the test, the accuracy of your test may be different, and that's a challenge for us right now. So someone who's had symptoms for several days, they might go get tested and be negative, and actually they had COVID, but it was so far past the start of their symptoms, then the collection wasn't able to detect it. All right, so the types of tests that are given, nucleic acid amplification testing detects the viral RNA using molecular methods. And the one that's most commonly used, the one that I had, is called a PCR test, or polymerase chain reaction test. This tests for active infection. It is based on the unique genetic sequence of SARS-CoV-2, which is the official name of the virus that causes COVID-19. Specificity is very high for PCR tests, but sensitivity varies based on the timing and the way the sample was collected, as I just discussed with you. So if you get a negative test with the PCR, it's quite likely that it's negative. That's what that specificity means. Okay, so the sample collection issues that I talked about are some of the issues with PCR testing. You have to really stick that swab so far in there, so you might get a false negative if you weren't able to gather enough viral material. You can use what's called a nasal swab, where it doesn't go as far into your nasal cavity as the nasopharyngeal swab does, but it probably also reduces the sensitivity of the test. And then saliva and blood samples likely result in even lower sensitivity for the PCR test. And then timing of specimen collection, as I said. That amount of virus changes over time. Ideally, you're collecting it at the onset of symptoms, but if it's collected prior or later, you may have a false negative. All right, next one. Antigen testing. Antigen testing also looks for active infection, but it looks at a different part of the virus. So instead of looking at the viral RNA, it looks at the proteins in the virus and pieces of those proteins. It also tests for active infection. It uses a nasal or a throat swab, so you don't have to use the nasopharyngeal. Typically, an antigen test gives you much more faster results. A positive test, just like PCR, means you have an active infection. A negative result simply means that proteins were not detected, but does not rule out COVID-19. So this is the challenge with the antigen tests. And a lot of the places people are going to get a rapid test are getting an antigen test. And so if you're symptomatic and you get an antigen test and it's negative, typically if you're being seen by a doctor, they will have you take a PCR test after that to confirm that what you have is indeed not COVID. So while it's less expensive than a PCR test and typically a lot faster, it doesn't definitively rule out those not infected because it's less sensitive. And so that's one of the challenges with the antigen test. The other challenge, and I mentioned this previously when I was talking about how laboratories do testing and look at sensitivity and specificity, is that with COVID-19 and the massive pressure to get testing out, some of the rigorous methods that labs go through, that they're required to go through by the FDA, have been relaxed through this process. There's what's called Emergency Use Authorization, or EUA. And while they've gotten approval for their tests based on what they've done, it's not the same rigorous process. And so some of the specificity and sensitivity is less than we would like. The final testing is antibody testing, and it detects the immune response in a person. So it tests for past infection, and it may indicate a period of immunity, which we'll talk about in a minute. Usually with this test, it's a blood sample, and a positive result means a person was infected with COVID-19 in the past and has developed antibodies that they developed in order to fight it off. You may get a false negative test if you test too close to the onset of an infection. So if someone has active COVID and they've only had it, let's say, for less than 10 days or 14 days, an antibody test will not be positive even though they actively have COVID. And that's because it's not testing for COVID, it's testing for the antibodies that developed in response to COVID. It's not looking for the virus, it's looking for the antibodies. And then if you're too far past the infection, because we don't know how long you might have immunity from the antibodies, and you get immunity by those antibodies staying in your system for a period of time, since we don't know how long those will last, potentially, let's say you had COVID 8 months ago, if the antibodies aren't lasting that long, you could get an antibody test and it would not detect that you had had COVID in the past. The other thing is that in any area, geographic area, where there haven't been many cases of COVID-19, you will actually get many positive results, which are false positives. And the reason for this is that antibody tests, some of them have low sensitivity and low specificity. So what this means is if a test isn't as good at determining negative results, it might produce a positive result that isn't accurate. And if the incidence of COVID in an area is lower than the failure rate of the test, then you could think you got a positive and you really didn't. So that's a problem with some of the antibody tests and why you haven't seen a big focus on antibody testing yet, because it's not as accurate. All right. Some antibody tests may also cross-react with other coronaviruses that are not SARS-CoV-2, and that could lead to false positive results. So again, because of the sensitivity and specificity, you're looking at antibodies to COVID, antibodies to a coronavirus. And depending on the type of test, it might detect those antibodies, but it might not have been the SARS-CoV-2 coronavirus that it detected. Again, immunity is unknown, so the presence of those antibodies over a period of time may not be accurate in telling you that you had it in the past. The use of the test can help identify people who could donate convalescent blood plasma. So once you've had COVID and those antibodies are in your blood, if you donate plasma at the blood center, that plasma can be used to treat people who are fighting an active infection and have not developed the antibodies to fight it. It's being used locally, even convalescent plasma. And so we're really encouraging people, after you've had a positive COVID test and enough time has passed, and I think it's at least a few weeks, you can go and donate your plasma and maybe save someone's life or help them recover from COVID. So if anybody's out there and they had a positive test, go donate plasma. I'm going to make my son do it too. And then eventually, as we get further in the pandemic, as we get that incidence of COVID higher, then the public health department could begin using things like antibody testing to give us some idea of where we might have a little more community immunity in terms of making decisions about reopening and such. But we're not there yet, unfortunately. Okay. That's my lecture for the day for learning about COVID. Now you're going to get another lecture from me. Right before I came down here to do this update, I sent out an email that I didn't want to send. It's basically letting all of you know that you're going to face disciplinary action if you don't wear your masks when you're at work. I wish I didn't have to send that out. I wish I didn't have to remind you. But this is a pandemic that's that's gone on for a long time, and it's going to go on for a lot longer. And just like those of you who remember how you had to learn how to use your seatbelt, remind yourself to put it on, at least I did. I grew up in a time where you didn't have to wear a seatbelt. I remember laying in the back window of the car when we went to visit my grandparents. And then as seatbelts became mandatory, I can remember when I first learned how to drive, sometimes I would forget to put it on. I never forget to put it on now. But in the beginning, I would forget to put it on. And we know that seatbelts save lives. We know that masks save lives. And more importantly, it's a mandate. And whether you believe that masks save lives or not, you have to wear your masks when you're at work. And that means you wear your masks all the time when you're close to anyone, when you're in public areas or common areas, coming to and leaving work. We hope you do that when you're outside of the work setting as well. But what this means is you don't sit nearby a coworker while you're both eating and you have to have your mask off. If you take your mask off to talk on the phone for some reason, it shouldn't be in the presence of a coworker, even if they're masked. So we really cannot emphasize enough the importance of following this mandate. It is so easy to be tired of this. I'm tired of it. I wish I didn't have to wear a mask. I have a mask breakout right around my mouth. It's just, it is what it is. And furthermore, you know, we know that that we want you to be physically distant. We want you to wear your mask. And if you don't, then you're going to be subject to disciplinary action. I wish that wasn't the way it is, but I don't know any other way to do it. It's easy to become complacent around your coworkers. It seems like we have a heightened awareness when we're interacting with the public or the people we serve, but when we get around the people we know, it's easy to kind of relax those precautions. We need to treat our coworkers like they have COVID too, or that we're protecting them from the COVID we might have. And so your coworkers need to be treated just like a stranger. That's hard to do because you guys have worked together, some of you, for a long time, and it's real easy to relax those precautions. But that's really where we have the highest risk. We think that that's probably where most of the spread is happening, not when people are out in the public, but when they're around people they know or getting together with large groups of friends, getting together for holidays, family barbecues, that type of thing. We're not going to get through this pandemic in any easy way, shape, or form if we keep having outbreaks, and we don't want to contribute to that. So please, please, please wear your mask. Don't put myself or your supervisor in the position of having to discipline you because you're refusing to wear a mask or forgetting to wear a mask. And so I hope I never have to bring this up again. But with that said, I will go to questions and answers. Okay, somebody just said they appreciated the email. That's good. I'm glad that you appreciate the email. I'm going to look at my phone and see if we have any other question. All right, when a person in the community identified as being positive for COVID and refuses to comply with COVID precautions, can public health step in and place that person in involuntary detention? Well, this is an interesting thing, and I've actually dealt with it a few different times where we've had someone who tests positive that because of some other underlying condition or what have you, they're refusing to comply with the precautions. If public health is made aware of that, when you get tested positive for COVID or you're identified as someone who was exposed, you actually get orders from the public health department, and those orders are legally binding documents. And that could include, depending on the situation, we could put an ankle monitor on you, we could direct you to stay in a particular location. There are activities that can happen and that have happened in our community during this pandemic when we're concerned that someone who is unwilling or unable to comply with the public health orders is a risk to the public. And so yes, we have taken additional precautions and public health can step in. It is legally binding, and county council is part of our conversations in terms of what are the resources, the tools we have to follow through on these orders, and so we do that. If someone is asymptomatic, they may actually be hurting those they are around without knowing it. Yeah, this is one of the more confounding things with COVID-19 and confusing. So when it first started, we didn't understand that you could be carrying COVID and not have symptoms. So with many viruses, the period where you're most at risk of being contagious or infecting others is associated with the development of symptoms. So once you have those symptoms, you're contagious, and we tell you stay away from people until the symptoms go away. But with COVID, we've learned that there's a period of time what we call pre-symptomatic for individuals who are going to become symptomatic, and asymptomatic for people who have COVID and never seem to develop symptoms that they're aware of. Occasionally, when you talk to someone after a positive test, they'll say something like, oh, that's funny, now I recall like my taste or my smell was off the last week or the last few days, or they developed that after the positive test, but may not have symptoms that are really profound in a way that they would recognize. That's why we wear the mask. So in the beginning, we said, don't wear a mask, it's not necessary, and then that changed when we found out that you actually could spread COVID without being symptomatic. And so the mask, remember, is the last barrier of protection. It's not the first, it's not the best. The best thing to do is to stay away from people. That's why initially it's stay home. If we all had stayed home, if every single person in the world had stayed at their home and not interacted with anyone else for like a month or two, COVID would have been contained. But that was proved to be impossible. So the very best thing to do is to stay away from people. When you have to interact with people, staying more than 6 feet away. I think we'll find over time that more than 6 feet is even better, but that's what the recommendation is now, to stay as far as possible and at least 6 feet away from people. And that's because when we're talking, when we're breathing, when we're singing, when we're yelling, little respiratory particles are going out in the world and landing on objects and landing on you, maybe on the front of your mask and such. And so we're telling you to wear a mask so that there's a barrier for those respiratory particles that are coming out of your mouth and out of your nose to not spread as far. Is it perfect? No. Are the cloth masks less effective than N95s and surgical masks? Absolutely. But they're better than nothing. And slowly but surely some articles are coming out and showing that depending on the fabric and the number of layers and how the person's wearing it, it can be almost as effective as a surgical mask. More importantly though, it slows it down. Even if it's not perfect, even if it's only 5 or 10%, better for you to get 5 or 10% less of my infection than me just to be spewing it all over you. And so wearing the mask is a safety precaution. It's more important, the person who has the virus is the most important person to have the mask on, but we are starting to believe that it's really important for everyone to have the mask. So even though you're wearing it just in case you might be asymptomatic and carrying the virus, we do think it provides you with some protection from other people who might have the virus. So, you know, this is a new virus. It's something we're learning a lot about. I think it's frustrating when the guidance changes, but it's not that you were lied to before. It wasn't misinformation, it was a lack of information. So as we learn, fortunately, as we learn more, we're changing the guidance. Oh, thank you for asking this question because I meant to bring it up myself. Any updates or information regarding the telework consideration surveys we completed 2 weeks ago? Yes, so they actually got completed about a week ago was the deadline to getting them in, and we have produced essentially a report about that should be coming It's been a great experience to get this information from all of you. What we've directed the supervisors is to make some arrangements with each of you that last at least 4 weeks while we sort through these questionnaires and really understand how to best meet your needs as well as the needs of the people we serve. Lots and lots and lots. I printed out 16 pages of comments, and I haven't gotten through them all. I've skimmed all of them and read through about a quarter to a half of them. It's a lot to get through. And I would say generally that what I really heard there is that people are trying really hard. Many of you are anxious and scared because you're really trying to balance the needs of the demands in your home with wanting to meet the needs of the people we serve, get your job done, and keep, staying employed. And so we share those concerns with you. And, some of the feedback on the survey as well was, this doesn't seem fair. I don't have kids. Why does someone get special consideration? And I think I said this last week or the week before, and I'll say it again. This is an unequal situation. We're in an emergency. This is a pandemic. We've never dealt with this before. We've never had virtual learning for kids. We have lots of staff who have kids, and we have to accommodate that need. It's going to feel unequal between staff who have kids and don't have kids. And all I can tell you is we've worked really hard throughout this entire time to be as flexible, creative as we can to both meet the needs of our staff as well as meet the needs of the people we serve. And when we can, we'll be equitable, and when we can't, we'll just simply acknowledge it. And I want to acknowledge that. So you should look forward to seeing something a little more formal. Again, if you have pressing needs, you should already be working with those with your supervisor. You should have a plan in place that you can rely on for a few weeks while we sort through maybe some additional options we could give you that might better meet your needs or better meet our needs. And so this will be an ongoing process. This isn't going to be a one and done. We're not going to view the questionnaire, come up with a few options, and then move on to something else. This is going to be an ongoing process as needs change, as your needs change, as our needs change, as restrictions come and go. While we're watching the case rates and such, we may have to modify some of those arrangements. And so, mostly we just ask for your patience, your flexibility. I really, I've said this many times, but this was mentioned in the questionnaire as well. We appreciate you. We cannot do this without you. And we also recognize that this is an incredibly anxiety-provoking time, whether you have kids or not, just simply dealing with COVID. Most emergencies don't last this long. Most disaster situations resolve much quicker than what this pandemic has. So we truly have never experienced anything. And we're all tired. We're tired of following the precautions. We're tired of the changes to our lives. We're tired of having to make these very difficult choices to balance home life and work life. And so we're only going to get through it by working together. We're only going to get through it by supporting one another. And I appreciate you. I really can't say enough about the passion, the dedication, the commitment that I've seen through this whole process, that we would not be where we're at without all of you. From turning to telework on a dime, and some of you really tolerating less than ideal conditions with lack of equipment or equipment that didn't work as well as we'd like it to, as we acquired the proper equipment and began to outfit you all with it, to coming into work when we needed you to, staying home when we needed you to. I can go on and on, but we appreciate you. And we're only going to get through this by continuing down this path of working together, standing together, working apart. All right, I'm going to look and see if there's any more questions. Okay, as we know, the pandemic is going to continue for some time. Is there an extension of the time that the emergency homeless shelters will be in place for our clients in need of a place to stay to avoid spreading the virus? Right now, our plans with our existing funding is to keep the shelters open at least through the end of this calendar year. So another several months, we have the funding and the structures in place. I do anticipate that even as time goes on, that we'll have to figure out extending that if we need to, and particularly the situation we have where we can isolate individuals in motels as well as trailers when they are testing positive. So we will continue with that as best we can, providing that ability to isolate people and give them a safe place to stay where they're supported while they get through the positive process. Of course, this is pending not needing hospitalization or such. And so, I'm helping to be in charge, facilitating the process of how we support homeless. And so I'll keep you updated as we go along. And, we've pushed that date further and further as time went on, and I do anticipate that we'll push it out even further as the pandemic continues if we don't get to a place where we either have a vaccine or adequate treatments to get this under control. All right. I think that's it for the questions right now. Again, you can email me if you're watching this in a recorded version or you think of a question after this session ends. Thank you for all you do. Wear your mask. All right, bye. Have a good weekend.